Hi, everybody. This is episode 66 of Artificial Intelligence and Cybersurgery. This is the official podcast for our journal, Artificial Intelligence Surgery, the first journal dedicated exclusively to artificial intelligence and surgery. I have here today with us my good friend and former housemate, Dr. Rahul Shah, spine surgeon par excellence. It's great to see you, my friend.
It's
Can
great to be
you
here. Thanks for having me.
so my co-host Vincent Grasso is busy putting out some fires, I believe somewhere. We won't get into details, but Rahul, can you remind us how we know each other? Or you
Gosh,
know what? Let's go back a little further, actually. Remind me where you're from and maybe where your family's from, and we'll take it from there. Go to where you went to school, your training, and then how we met.
yeah, it's been a little bit of a ride. So I was actually born in Ndola, Zambia, and my family's from India. So we kind of do the migration route all the way from Western India down to Africa. Then I was in uh, Georgia is where we first came to the United States, and then I basically grew up in New Jersey, and that's where I'm practicing now. Yeah, so I grew up in New Jersey. I was part of a combined medical program at Rutgers, and I did that. And then I went over to do my surgery internship and orthopedic surgery at Yale, where you and I met. Um, I was staying in your house while actually you were away on sabbatical, I think, doing some work in, I want
Yeah.
to say Paris, right? Because you had that arm injury.
Let me think. No. So that was when I was in Italy, then in Verona.
Yeah, that's
Yeah,
right. That's
University of
right.
Verona. Yeah.
Yeah. So then I was there, and then you and I roomed together for a little bit,
Yeah.
um, and then from there I finished up at Yale, and then I went over to University of California in San Francisco.
Mhm.
Did some surgery and deformity surgery and advanced spinal surgery out that way.
So
Then I was
that's where you did your fellowship at UCSF?
correct.
Fancy, my friend. I did not realize you were at UCSF for spine.
Yes.
I'm impressed. Excellent.
Yeah.
Excellent.
Yeah. So I had I was out there for a little bit, and then from there I was in Orlando for about a couple of years, and then I basically came down to Southern New Jersey, and I've been practicing here for some time since.
Is this the same area of New Jersey where you grew up?
Slightly south, about an hour south. It's a little less populated because where I grew up was a bit more densely populated. So this is more of an underserved area, at least when I came here, but it's all kind of coming together. So I'm in closer to the southern New Jersey, basically just outside of Philadelphia area. So all of
Okay,
the
nice.
southwest area
Yeah,
of
yeah, I know it well. I used to go through a lot when I worked at Fox Chase Cancer Center. So yeah, yeah, beautiful, beautiful. So you've been doing what type of spine surgery do you do now?
I do all sorts of spine surgery, basically anything from the base of the skull all the way down to the pelvis. I do neck surgery, mid back surgery, low back surgery,
Yeah.
anything from smaller discectomy type things to smaller fusions to multiple level fusions and the scoliosis correction surgeries as well.
And you put in implants like spine implants? I'm trying to think what they're called, like the charité.
Yeah.
What are they called again? The
There's different types, exactly right. Because you and I wrote a paper on revision spine surgery for
yeah,
the anterior approach. That's right.
right, right,
Um,
right, right.
yeah, so all sorts of implants, right? It all depends, but
What
basically,
are they called when it's a disc? Is it
yeah,
a
you have disc replacements, you
yeah?
have rods and screws, you can have plates. So there are multiple types
But
of
have they developed an implant that actually works now? Because I remember back, when I was kind of interested in this topic, I don't think they had found the perfect solution for that, or have things changed, or was I wrong?
No, I mean, look, it's an evolution and process. Really, what happens, the way the spine works, is that it's like a series of bones that stack up one on top of another, and they work through hinges, basically, right? And that hinges through the disc in the front and the facet joints in the back. And those are the areas that are going to wear out, sort of like hinges on a door. That
Yeah.
they can wear out. And so what we do is we try to say, oh yeah, that hinge is worn out. We're going to go ahead and rebuild that hinge. But the milieu, the context is so complex because you have muscles, you have nerves, you have
Nerves. Yeah. Blood
and so
supply. I'm imagining that can't help.
exactly.
Yeah.
Exactly. So all of that has to be taken into account. And we engineer pretty good solutions, but the reality is that the motion preserving stuff like the Charité disc, which is what we wrote about, and then we have Pro
Yeah.
disc and stuff like that for the lumbar spine and for the cervical spine, it's come out and it's done better for the cervical spine because the loads in the cervical spine are less, but in the
Yeah,
lumbar
just
spine,
less weight, right? Yeah.
correct. Because this is supporting the head down in your pelvis, it's supporting your whole back and whenever you torque, whenever you get
Even the thing God invented doesn't work too well, right? We all have a little bit of low back pain, so it's a tough part of the body, right? To get
it
us
is.
upright. So
It is. And to stay upright, because over time we sort of get a little bit more arthritic, those areas, as we all get a little bit older, we start to bend forward a little bit. So those are part of the forces that we have to take into consideration. And, that's what really connects in this type of scenarios because I'm talking about the researchers and the folks that are working in the labs, when we're looking at this, we're looking at the individual disc or the individual unit or the individual hinge. We call it the functional spine unit.
yeah.
We're looking at that and seeing how that works. But the reality is that you have multiple of these working together. So you need a lot of processing to be able to understand the different dynamics of each of these and how they work together. Because you have this sort of emergent property, this emergent like sort of system dynamic that occurs because one disc isn't the whole spine. It's the interaction of all the discs and the interaction of how you interact with the world that allows you to be able to see if your spine can hold up to the challenges of everyday life, getting in and out of a car, getting in and out of bed. You get the
I,
idea.
I love how you made spine surgery spiritual, man. You're the best. You're the best at this. So that reminds me, why'd you go into orthopedics? Did you know you wanted to do spine surgery from day one?
So I did not know I wanted to do spine surgery from day one. What I wanted to do, the reason I went into orthopedics was because I loved the ability to help somebody on their journey to walk again. Like to me, there was something very magical about that. Not that a lot of other parts of medicine are not magical, but to me, that really spoke to me.
Yeah.
So that's how I started my journey in orthopedics. And my initial idea was to do total joint surgery, like hip surgery or knee surgery, to try and get people to get past the arthritic pain that they were having and to be able to enjoy their life again, to increase their quality of life. When I was at Yale, I was one of the research fellows that they had. So it was one spot that they had for that. So I had matched into that, and so I spent a fair bit of time in Dr. Punjabi's lab, who basically probably has, if not the most, some of the most influential work done in spine, and he was at Yale. And in my time working through the biomechanics and understanding those relationships, I came to the realization that the spine was just basically a series of knuckles, a series of joints that just had a lot more impact because it was next to the nerves. Like there are nerves that run next to your hips and your knees, but they're not directly in contact with the ways that the hips and the knees move. Whereas the spine, where the hinges are, when they become
Oh yeah.
arthritic, they
Oh
can
yeah.
crowd out the nerves. So you
Yeah.
have a double whammy. And so in my view, the payoff of being able to help somebody in that world, if someone has an arthritic spine or has a deformed spine or has an injury to the spine that causes them to be off kilter in some way, not only giving their muscles a disadvantage of working, but also potentially jamming up their nerves, the impact is even greater than, say, an arthritic hip or an arthritic knee.
It's the ultimate joint. I mean, it's
Correct.
multiple joints. So, how does AI impact your, your work as a spine surgeon today? Like, do you see it helping you
So
build
many ways,
new
so
disc?
many ways.
Do you help it with like choosing patients? Do you help it with preoperative planning? Do you help with like decision support? Like, How
Whole
do you
gamut.
see AI working? Or tell me.
The whole gamut. But yeah, I mean, and I think I think the framework is perfect, right? I see it from the whole gamut. So from the beginning, AI, I think, will help. See, there's so much noise in spine. And if there's one thing that AI is good at, it helps you with enough data to be able to parse through the noise to be able to help you get to the real signal. So you have so many people that come in with MRIs, right? And they have 1,000 things that are wrong with their MRIs. We know this all the time in general surgery, right? Anybody that gets an abdominal CT, chest, abdomen, pelvis CT, there's always this thing called an incidentaloma. Which one's relevant? Which one's not relevant? Well, in spine, the same thing occurs. So I see a real role, and we're working on this, of being able to help the clinical correlation of understanding what we use as heuristics about if you have pain here, it's potentially referred to the spine over here. If you have pain over here or limitations over here, it's referred to the spine over here. As a matter of fact, we're working on some applications right now, and I'll share this with you again in the future, where we're working on identifying the different ways that people see spine or the pain that they experience. Because when you cut your finger, you know where your problem is. You can see it, but you can't see when you have a problem here and then sometimes over here and then sometimes over here. It's hard to put together. But if you have a way that AI can help to constrain that, to say these is where you ought to be seeing things, and this is where your symptoms are, and we can see that over time, AI and machine learning will leverage the experience of many people to be able to help put that clinical correlation into better perspective. And
I always felt like the from my point of view, the Achilles tendon of spine surgery was like, from my understanding, you guys had a hard time really figuring out if your surgery was going to be beneficial or not.
you got it. You got it.
Right, right.
Yeah.
So you're hoping that AI can help you choose your patients better, choose your what operation you do, when to do it, and
Mhm.
everything. And it
And
actually
risk stratify better, right? See little changes that we can't pick up
yeah,
because we're not necessarily seeing it, but and identify little changes because little changes in the spine, as we all know, have big payoff, right?
right.
Yeah, have a big downstream effect. So I think that that's something that we're going to be able to understand. So that's one place where AI and spine surgery come together. The second spot where I think AI and spine surgery come together is in terms of building patient-specific implants. And so as you and I have talked about, where I'm working with a company right now, which is in the process of developing specific implants that are allowing for the optimal distribution of load so that the implants that you put in not only are likely to stay where they're put, because you and I all know about implants that move out of position, right? So if it's in the perfect environment because you've calculated the environment much better because you have seen micro patterns on CT or MRI scan that tell you this is where the stress is likely to be distributed in this manner, you now have an optimal position to not only aid the person's pathology, but then reconstruct them in a manner that helps them to achieve a pivot that's stable and solid in an optimal position. So that's going to be something that's there. And you can do multiple versions of that ahead of time because you can see based on where those implants are placed, what the effect is going to likely be prior to actually putting that in. And so it will help the surgeon in decision-making process of what's the best fit. Because the computer may say this is the best fit, but then when you see it in action, you're like,
Yeah.
that action doesn't look harmonious. That doesn't look like it's going to be the best fit for this individual person. And so I think we're going to be able to cut down the one size fits all, number one, but to be
Yeah.
able to optimize where people are to meet them on their journey for recovery where they're at instead of trying to force them to our own predetermined small, medium, large footprints that we have right now.
So that's interesting. Like with cancer surgery, which I know you do. We look at multi-omics. We look at radiomics, genomics, pathomics, things like that. But just for right now, sticking to kind of like disc disease, what type of omics could you look at? Obviously, you can look at radiomics, but
Mhm.
is there's no biopsy that you would look at. There's no pathology slides that you would look at. You guys are pretty much limited right now to imaging to do this type of thing, or anything else that you could think of?
Well, one of the things that we're not, so stability is a big thing in spine, right? And the way you think about stability is this. Imagine a table that has four legs, right? If you take one of those legs and put it slightly off kilter, the table becomes slightly wobbly. It can't handle the loads that are put through it.
Yeah.
And that's what spine is, but we're not able to pick up right now with the radiographs that we have and our understanding of those radiographs if they're perfectly stable or if there's a little bit of wobbliness. Are they
Do you have a dynamic study that you guys do?
We do, but the dynamics actually, and this harkens back to the lab, the dynamics, there's a lot of play in between that you say is normal, but maybe normal for some people and not normal for others.
Mm.
So what we need to do is be able to really try and dial that in a manner that's universally accepted, so that people can see with AI and machine learning, what will happen is if we can dial that in and show pretty clearly what's right for this person and what's not right for this person, what this person can handle, what they cannot handle, that clarity will cut throughout not only treatment decisions, but it will help with approval processes, because in the US, a lot of things are not approved because they say, well, we're not clearly saying that these things are, this isn't necessarily beneficial for the patient. And so they use the absence of proof as a seal of approval that that's proof that it doesn't exist, which is not the case. And I think that AI will help to bridge that, where it will show if you have dynamic X-ray, flexion extension radiographs that says, okay, when you move in this manner, this is the way it is. But based on the differential of how you're moving at these segments, there's a mismatch, and that mismatch will typically point to this problem.
So
And
that's interesting. So I mean, your startup is essentially, or your concept to get a better, is it a better implant or disc? What term should
yeah,
I?
well, yeah, I think better implant as of now. Disc we'll get to, but I think implant as of now.
A better implant. So I mean, you're relying not only on, say, MRIs, but
Mhm.
you're also relying on X-rays, like flexion studies, like you were just saying.
And CT scans. And CT
And
scans looking
so
for
three. So you need
microarchitecture bones.
three. So you need three radiographic modalities. So
Mhm.
you're heavy. You're heavy on radiomics, but you're actually using three different ones, and you could create an algorithm that would combine all three.
But yeah, yes, and hopefully at some point we'll be able to take dynamic data, because we're not able to do that, right? Imagine a drone or a floating camera that's walking with you as you walk, to be able to see how the heat signatures change in the body as it works. We've tried to say that we're looking at that, but we're not. We're still very much in the infancy there, because it's so much data. We don't know how to parse out what's important and what's not important.
Yeah, definitely.
And you need something that literally is a workhorse to be able to get through that. And that's where I think AI makes a massive, massive impact.
So this startup you're having, how, explain it to me a little bit better. What's the concept behind it? What are you trying to accomplish with it?
So that's a very simple entry level problem that we're trying to solve.
I
But the
like the
effect.
sound of that already. Simple is means you can actually accomplish
Yeah,
a solution.
yeah. So what it does is it looks at, let's say we've identified that one disc or a series of discs are, or a series of joints are off kilter for some reason. Okay, they're either off kilter because they are not stacked correctly, or because they are squashing a nerve at some area. And let's say we have to take that area out and stabilize it. The goal with this type of product is to be able to engineer the optimal architecture of the stabilizing piece, such that when we put it in the place, not only does it restore the posture of the spine in an optimal alignment for that person, but that area is not likely to sink or shift, because it's kind of fits in like a hand and glove, and the forces that are going through there are equally matched above and below. And so we have fine element models that show, and there's an algorithm that's been patented that basically shows how to optimally arrange for the forces that go from one bone to another bone, so that this other reconstructive piece that we put in there, the cage or the prosthetic material that we put in there, is perfectly matched to that patient's anatomy and that patient's microarchitecture, such that it fits in like sugar and milk.
So I know what the cage looks like, and I was going to
Mhm.
ask you, and luckily you. So you're putting in cages, but
Mhm.
prosthetic material. What do you mean by that? What is?
That's what I meant. I just meant that the cage is what I'm using as the
So the
as
cage is the prosthetic material. Okay.
correct.
So you have an algorithm that can tell you, and excuse me for the phrase I'm about to use, because what you call a prosthetic or a cage looks a lot to me like an erector set. So
All right.
the erect, sorry,
Yeah.
the liver surgeon has to have a little dig at the spine surgeon, but though the bars and the screws and all that, you have an algorithm that can tell you like where to put the screws in, how many
Mhm.
screws, how many levels, and things like that.
Right. And how to optimally make sure that the load is effectively transferred from one bone to another, such that
Wow.
nothing is overstressed or nothing is necessarily likely to collapse. Because collapse is a big problem because then you're chasing the collapse. And so what it is like, it's like you're just chasing your tail because one problem begets another problem, which begets another problem. You're not necessarily making forward progress. You're just stuck in limbo.
And so to create that algorithm, what type of data did you analyze? All those three modalities like CT scan,
Mhm.
MRI, and flexion
And
extension studies, or what?
plus and using fine element analysis FEM, we the
What's that?
engineers
What's that?
of basically computerized algorithms that allow for understanding how if you put in a material, how each element of that material is, which forces it experiences, and how the optimal load distribution of the forces is, so that no one area is overloaded, point loaded than another area, so that because you have an even distribution of load, it's likely to hold in that position of where it's been placed.
Very
And
cool.
so
Very cool.
so
Do you factor in things like BMI and like presence or absence of diabetes, steroids, and things like that in the algorithm also, or no?
not yet, but some of those things are baked in because of the architecture of the bone, right? Because the architecture of the bone will respond dynamically to all of those factors. It does not, diabetes is the one thing that is a little bit more difficult to factor in because that in and of itself is a multifactorial disease, as you know. Muscle, the quality of the muscles, if someone is sarcopenic, we all know that they also have a higher likelihood of having abnormal glucose metabolism. We also know that uh, diabetes also retards the speed of healing because of the extra
Mhm.
the extra glucose in the system. So that is not quite factored in, but BMI, osteoporosis, osteopenia, local
So
factor
you're doing like
components.
radiomics on the actual bone, right? To see,
Correct. Correct.
okay, interesting.
Per level, not
Right.
just the whole thing.
Wow, wow. And are you also doing that on the MRI or just the CT scan?
No, you can do it on the MRI, but the CT is much, much better for that. So maybe over time the algorithm will adapt to that, but not just yet.
Oh, that's pretty cool. I'm trying to think. And so you're able to, the algorithm then is able to tell you like what optimal pieces of pre-existing cage pieces you should use.
Yeah, but at this point, you don't even need to do that. Ours is going to be a 3D printed
Oh,
custom fit
okay.
one that's individual is specific to that patient. Yes, you can potentially do that, but you're still then running into the fact of, am I putting in a small or a medium, or is it going to be a smaller or larger? Like you run into other issues. This is going to take a lot of that out for
And
you.
those implants are made out of
Mhm.
titanium?
Yeah.
So I don't know this. Are there 3D printers that can print titanium? I presume there are, but I don't
Yeah.
know.
Right.
Wow, wow. And I would imagine, does something like that, is that expensive? Does that already exist? Is that routinely how things are made now?
No, there are a couple of smaller companies that are doing that. The algorithm that I'm talking to you about is probably the most comprehensive and the most well tested in terms of optimal pressure point loading. But there is more of a custom fit type of trend in spine surgery where we're getting, like, for example, when somebody has scoliosis, we get rods that are sometimes custom fit. So
You
we're
can order
typically
you can order custom fit things now.
correct. But if you look at the market segmentation, it's a small fraction. And when I
Yeah.
say small fraction, I'm just talking well less than 10%, well less than 5%, somewhere in that range.
Okay, but this sounds really interesting. So is I don't know if we're getting too technical. Tell me if I'm getting too technical with my questions or too detailed, and if we have to stop recording. But is the company is based in America or in Europe or Asia or where?
It's still in the process of being formed, so it'll be formed in the US.
Okay, it'll be in the US. And well, you know what? I think now that I understand your project, I think, let me see. Yeah, I think we can end this podcast so that I can ask you some more interesting questions offline.
Yeah.
Rahul, it's great to catch up with you, and I'm also going to ask you, are you still publishing? Are you still writing papers? Are you still
So
interested in reviewing articles and things like that? Because
absolutely, but we just wrote. So I just did some stuff for posterior cervical spine with some minimally invasive cages, and we have the world's largest basically data set on 3-level fusions now, where we did just front versus front and percutaneous back
yeah.
fixation, and all of that's going through the process right now of being submitted for publications.
Oh, fantastic, fantastic. Okay, so Rahul, we're going to stop. Great to catch up with you.
Yeah.
And I'm going to hit